Hello, thank you. Welcome, everyone. Just waiting for a few more folks to come in, then we'll get started. Okay. So thank you everyone for joining us today. We're very excited to host this talk on non-psychiatric or secondary causes of psychosis, which I know is a really interesting and relevant problem that comes up for a lot of folks. As an announcement before we get started, we'll post this link towards the end of the call as well, but we want to start collecting feedback on our MapNet community calls. So please, very helpful for us if you fill out the form. It's just a minute or so, but we'll remind you again at the end. But I'm Kelsey Johnson. I am the program manager for MapNet here in Boston, working with all of our early psychosis programs to try to understand and help figure out some of the common problems that come up in this work. So we're very excited today to have our own Megan Good from the Aspire Clinic at Beth Israel to talk about this issue. So by way of introduction, Megan Good, MD, is the medical director of the Aspire Clinic here at Beth Israel Deaconess Medical Center in Boston. She completed an early course psychosis fellowship at Beth Israel and Harvard Medical School and her psychiatry residency in the University of Louisville, where she served as chief resident. So her research work is focused on non-psychiatric contributors to psychotic symptoms. She's a dedicated advocate for individuals and families who are affected by psychotic disorders, and also a proud Kentuckian. So very happy to have you, Megan. Thanks for joining us.
Thank you so much, Kelsey. Hi, everyone. I know quite a few of you, so it's wonderful to see you again. My name is Megan Good, Dr. Megan Good. I'm here today to talk to you about a case of mistaken identity, which is unmasking non-psychiatric causes of psychosis. And this is really a topic that sits in the intersection of neurology, internal medicine, and psychiatry. I'm going to try to speed run about a week of medical school in an hour, so that'll be very fun. Our goal today is, again, to learn how to unmask these non-psychiatric or secondary causes of psychosis. And these are cases when the brain is reacting to a physiological insult rather than an idiopathic psychiatric condition. By the end of this session, we will be able to clearly define secondary psychosis and distinguish it from primary disorders like schizophrenia. We'll identify the major medical etiologies, recognize the red flag clinical features that should make you suspicious of a medical cause, and walk through a systematic diagnostic workup for patients presenting with first episode psychosis. Throughout the presentation, you'll see some cats. They look like this, varying levels of craziness of these cats. I've included these because these are a really wonderful example of the product of someone who had secondary psychosis. So this is Lewis Wayne. He's an artist from the early 20th century. He's going to lead us through the presentation because, again, he had secondary psychosis from a traumatic brain injury. He was climbing into a carriage and fell and hit his head, and again, had perceptual disturbances, mood disturbances like depression, some other more neurological symptoms the rest of his life. And so, as the presentation continues, I want you to pay attention to how his art changes as his symptoms and his brain evolves. All right, so first section is Introduction to Secondary Psychosis, aka non-psychiatric psychosis. I think secondary psychosis is what most literature and what most people refer to this topic as. I personally like non-psychiatric causes of psychosis because we'll get into this a bit more, but psychosis is a symptom. So attributing it to psychiatric or non-psychiatric causes seems more accurate to me than just saying primary and secondary. So again, when we talk about secondary psychosis, we're moving away from this black box of idiopathic mental illness where we're looking for a direct physiological smoking gun. We're looking for a medical problem where psychosis is usually only part of the presenting symptoms. And let's look at what this actually means in a clinical setting. So, one thing before we get into secondary psychosis, I want to be very clear on is that, yes, this is a topic that's primarily in the medical realm, but anyone on the coordinated specialty care team can pick up some of these symptoms and bring them to the attention of the psychiatrist, whoever the providers are on the team. So, simply put, secondary psychosis refers to psychotic disorders that are a direct result of a known medical illness or substance use. Unlike schizophrenia, which is idiopathic, a primary cause in and of itself, the essential features here are prominent delusions or hallucinations that can be attributed to the physiological effects of another condition. The key diagnostic criteria, it must not be better explained by a primary mental disorder. So the key cause we're looking for is non-psychiatric in nature. How common is secondary psychosis? So is this a zebra or is it a horse? That's a common thing we say on the medical side. Horses are common, zebras are rare, but zebras do exist. So which one is secondary psychosis? The data suggests that secondary psychosis is not common, but it also isn't rare. So one study in 1987 surveyed 268 patients. They reviewed charts of 268 patients and found that about 3% had contributing medical comorbidities to their presentation of first episode psychosis. What's interesting is that secondary psychosis is actually more prominent in children and pediatric patients. One study showed out of 160 patients who presented with first episode psychosis, pediatric patients, 12.5% of those patients had contributing and comorbidities that were medical in nature. And that makes sense to me because that goes outside of the traditional presentation of schizophrenia, schizoaffective disorder, bipolar disorder, etc., which typically manifest in your early adulthood. This is happening in childhood. More than likely, there's something medical going on. But in general, I do think this is common enough. It's not rare that it's very important for everyone involved in coordinated specialty care should know about secondary psychosis and how to identify it. I did want to mention that seeing these medical causes of psychosis is much more prevalent in older populations. We really need to view psychosis as a symptom and not the pathology in and of itself. So I like to use the fever analogy. So a fever is a clear sign of distress, but it doesn't tell you a cause. A fever could tell you that a patient has an infection, that there's an autoimmune flare, that the patient is having heat stroke. We should view psychosis the same way. So it's a manifestation that the brain is not doing well. The brain is having a dysfunction. And it's our job to determine if that disease driving that brain dysfunction, it's a primary psychiatric condition or a secondary medical one. And again, with the lifespan, as we move across the lifespan, the significance of secondary psychosis only grows. The lifetime risk of developing some sort of psychosis later in life is about 23%, so very high. Again, as people get older, their brains have more dysfunction. So we may see psychosis as part of that. And remarkably, among older patients presenting with the first episode of psychosis, a 60% will have a secondary medical cause, which makes complete sense to me. Because these older groups carry that high medical burden, the prevalence of non-psychiatric psychosis increases naturally with age. In the field of mental health, how have we viewed and conceptualized secondary psychosis? Well, actually, it's been something that's been a consideration from the beginning. To understand where we are, we have to look at where we come from. And for over a century, psychosis were split into organic, those with a clear brain pathology, and functional, which was often blamed on physiological factors like an upbringing, schizophrenic mother, those sort of concepts. It wasn't until the DSM-4 in 1994 where we dropped these terms in favor of psychosis secondary to medical illness. And currently, the way the DSM-5 defines secondary or non-psychiatric psychosis, it refined it to emphasize that these are symptoms of another specific medical condition or substance. So again, the DSM-5 TR is really emphasizing that psychosis is a symptom and not an illness in and of itself. What are some red flags for secondary psychosis that we can look for in our patients who, especially those presenting with first episode psychosis? First, it would be an atypical age of onset, so either very young, children, or very old. So people over 40 and people that are, maybe lower in age, like maybe like preteen, elementary school age, are very unlikely to be displaying a primary psychiatric disorder. This isn't the normal. If they are displaying those symptoms, it's definitely not the normal course of the illness, and you should definitely be looking more into a secondary or medical cause to their psychosis. We also want to look for a rapid onset of symptoms. So if the symptoms just happened overnight and the patient comes in and they come to the ED, they're floridly psychotic, that is definitely a red flag for a secondary or non-medical psychosis. If the symptoms developed over a longer period of time, then that's more consistent with a primary psychiatric disorder. We also see in patients who have secondary psychosis non-auditory hallucinations, like seeing or smelling things. Olfactory or visual hallucinations are very in line with with secondary psychosis from a medical condition. And we also know that if a patient has a known medical risk factor, like a history of head trauma, or their symptoms just aren't responding to antipsychotics, your suspicion for secondary causes should be very high. So I always like to talk about why things matter, right? We're here together on a lecture on a Friday afternoon, why morning really. Why does this matter that we're learning about this? Well, it's because many secondary causes of psychosis are entirely reversible if caught early. And in older populations, roughly 60% of new psychoses, again, have a secondary cause. So it's not, in our patient population, it's not common, but it's not rare. Older populations, in the elderly, it's very common. An accurate diagnosis really does fundamentally change everything, which is the treatment plan, the specialist that we would consult on an inpatient unit, and ultimately the patient's long-term prognosis. We owe it to our patients to be accurate in their diagnosis and treatment from every member of the care team. Um, let's talk about some causes, the most common causes of secondary psychosis. Broadly speaking, psychotic disorders can be characterized as either primary or secondary. These conditions present across the lifetime. If you see the different categories of secondary psychosis, you'll notice that almost every body or organ system has an associated secondary or medical cause, non-medical, non-psychiatric cause of psychotic symptoms. We're going to talk in a lot of detail about some of these causes, but big picture is to zoom out and really get at what's important isn't to say, oh, these are the individual infectious causes, these are the individual genetic causes. Although, of course, I want you to walk away with a knowledge of that. It's just the fact that psychoses are often part of a cluster of symptoms that is secondary in nature to a medical condition. So Oftentimes, these secondary causes of psychosis isn't the only presenting symptom. There's usually something else with it, and it may be helpful just to get a bit of an idea of what those other things are. Here are some specific medical causes of secondary psychosis and others as well. We'll only talk about some of these. We could have a lecture on each of these, and it's still probably not be enough information. So we're just doing an overview of these causes, just so you understand that from a medical perspective, what we're looking at and what we're looking for when we're trying to identify non-psychiatric causes of psychosis. This is a mnemonic that Dr. Keshavan came up with. I think it's always good to have ways to remember these things, especially in your clinical daily practice, so you don't need to be looking them up. It's just in your brain for you to access. Interestingly enough, there are some psychopathological differences between secondary psychosis and primary psychosis. So the symptoms associated with each. This was a meta-analysis that I took a look at that I thought was like quite interesting. Visual hallucinations and poverty of speech were very much associated with secondary psychosis or non-psychiatric psychosis, whereas symptoms like auditory hallucinations, thought insertion, thought broadcast, delusions of persecution, olfactory hallucinations, and tactile hallucinations were associated, at least in this meta-analysis, with primary psychosis. I would say that tactile hallucinations, at least in my clinical practice, are definitely more associated with secondary psychosis, same with olfactory hallucinations. But in general, you can see that there is a split with some of these symptoms. All right, first and foremost, let's talk about neurological causes of secondary psychosis. These are major culprits. Epilepsy or seizure disorders carry a 7% risk of psychosis, whereas 4% of MS patients have some sort of psychotic symptoms. Psychosis can also be the presenting symptom for MS as well in rare cases. And up to 10% of those patients with Huntington's, frontotemporal dementia will experience psychotic symptoms as well. And then we also see psychotic symptoms in the case of brain tumors, strokes, and CNS infections like HIV or neurosyphilis, which we'll circle back to CNS infections in a bit. To talk more about these, again, neurologic symptoms, causes are by far the most common culprits we see in clinical practice. I often think it's really fascinating that we have our friends and colleagues in neurology, and we're both working with the same organ. We view our practices slightly differently, and the pathologies we work with are slightly different. But this is truly where the two come together in an undeniable way. Many neurological pathologies that result in secondary psychosis involve areas of the brain that have to do with perception and thought. Epilepsy, we see psychosis with partial complex seizure, with temporal lobe epilepsy, specifically. We also see psychotic symptoms in patients who are having seizures and also after they have seizures. So ictal, meaning during the seizure, and post-ictal, after the seizure psychosis. If you're suspecting this clinically, you would want to get what's called an EEG, which is where they look at a patient's brainwaves and they can tell if they're congruent with a seizure or not. Space occupying lesions or brain tumors are a rare cause of psychosis. We see these a lot in case reports. We get asked a lot, at least I do get asked a lot about these by patients and family members. Could this be a brain tumor? And rarely, but sometimes interesting, yes. This imaging is from, actually, this is a kid, I think. School-age child who was having command auditory hallucinations from the devil. they scanned their head. They found this space occupying lesion. Is it? I think it's in a yeah, it's a ependymoma. Um, and when they removed it, the child's psychotic symptoms rapidly abated. So very rare situation, but also very fascinating as well. Next is strokes, especially patients with strokes to the frontotemporal region of the brain. 4% of strokes have some sort of psychotic etiology, and most likely to be visual, tactile, or olfactory in nature. This is another case report. This is a 53-year-old woman who presented with 6 weeks of progressive visual hallucinations and delusions, no psychiatric history. This was after a large right middle cerebral artery stroke, and which was complicated by hemorrhagic conversion, so like bleeding. Um, and let's see, what was her outcome? She also had some paranoia, believed that husband was sleeping with a neighbor, also had hallucinations of strangers. I don't think they really commented on, if I'm remembering correctly, they really didn't comment on outcome, but they were just documenting, like, hey, this is really interesting that this stroke resulted in these paranoid delusions, as well as multiple types of hallucinations. And then head trauma as well. I know head trauma is something we always screen for in our evaluations for our patients at Aspire. TBIs or traumatic brain injuries do marginally increase the risk of psychosis with a greater increase in people who are already predisposed. The way I always conceptualize this is that these are patients who were already at risk, and a history of TBI or multiple concussions maybe is something that's pushing them over the edge to having that full psychotic break.
We have two questions in the chat. First is, do those symptoms come on quickly, or is that something that develops more slowly?
As for is there like a specific cause
I think
that they're
for the neurologic causes, but correct me if I'm wrong.
neurologic? I mean, it would depend on the cause because something like something like a tumor would be slow growing. But maybe neurologic causes. I mean, it really depends on what it is. With epilepsy, you may see it with the seizure pretty immediately because it would be during the seizure or and shortly after the seizure. Strokes could be either or, I would think. Um, but with neurologic causes, I think it's more variable than maybe some of the other causes that we'll talk about. Great question.
Yeah. And then, yeah, two things that maybe you might talk about these coming up. But first, autoimmune diseases and encephalitis. And secondly, is there evidence of psychosis occurring with the onset of menopause?
There is yes, there is. There's some evidence of that. I don't specifically talk about that in this talk, but yes, there's some of that as well, which is quite interesting.
Sorry, and another one just came in as we were talking. But so when you said 60% of older patients with a new incident of psychosis have a secondary cause, what's the age that you're defining as like an older adult?
Like 60, is it 60 plus, I believe?
Okay, yeah. So outside of the range of the kind of youth programs that we're working with,
Yes.
but yeah,
Yes,
yeah.
definitely. Yeah, I definitely want to call attention when there's age-related changes. I'm glad whoever submitted that clarified with that. A lot of these are things that we would see. Maybe they would be helpful to clarify what would be more likely to see in our young adults that we treat and who's older. I think it's still worth pointing out some of these secondary causes of psychosis in older adults just because it is so frequent, but I'll definitely point out the ones that we're maybe most likely to see or that I've seen in my practice. Thank you. Great questions, everyone. Please feel free to add more. And then lastly, talking about different dementia type illnesses like Alzheimer, Lewy body, and Parkinson's disease. Again, very, very common. Alzheimer's disease, 40% of patients have some sort of psychosis. Oftentimes, this presents in the form of delusions. I've seen, people who feel like they don't know where their keys are and where things are. Maybe they get confused about their exact location. And over time, as their brain becomes more and more dysfunctional, that becomes more of a delusion than just like a confusion picture. And Lewy body dementia is really fascinating. It's the type of dementia where visual hallucinations are actually a core diagnostic feature of the illness. So very fascinating. And then lastly, Parkinson's disease, especially Parkinson's disease with associated dementia. Up to 50% of those patients have some sort of psychotic symptoms, especially visual hallucinations. That's because Lewy body dementia and Parkinson's disease are both connected. And it's believed that this specific brand of psychosis is probably related to cholinergic deficiency. This really speaks to the fact that psychosis, again, as a symptom, doesn't have a single etiology. We know how some psychosis works in the brain, but if you really get into buy into the theory that there's, and I think most people do, think it's like a pretty accepted thing that there's different types of psychosis from different types of different origins in the brain, different neurotransmitter systems, et cetera, then you're going to see maybe slightly different symptoms or slightly different ways to treat them. All right, next let's talk about endocrine causes of psychotic symptoms, specifically thyroid and your parathyroid. So the endocrine system is definitely something we always look into when we're doing a medical workup on a patient with first episode psychosis. Both hyper and hypothyroidism, so high thyroid or low thyroid, can cause psychosis. And this is because the thyroid hormone is just such a powerful driver of multiple systems in the body. And it's very important to the brain as well. Thyroid hormone can disrupt imbalances. So that's why it's hypo. It's really just like a huge change in thyroid hormone up or down can disrupt brain metabolism as well as neurotransmitter systems. So that's when you can see some psychotic symptoms. Parathyroid disorders are also critical. The parathyroid are these little glands in the back of your thyroid. They modulate your calcium. Calcium is really important with how neurons fire. So if you're disrupting calcium in the brain, then among other things can result in psychotic symptoms. And again, I want to keep calling attention to the fact that these symptoms wouldn't occur, these psychotic symptoms wouldn't occur in a vacuum. There'd be a lot of other physical symptoms going on as well that result from calcium dysregulation, but we're just focusing on the psychotic symptoms. Some other endocrine causes are your adrenal glands. Adrenal glands produce cortisol and a couple other very important hormones. They sit on top of your kidneys like little hats. This is a well-known trigger for psychotic symptoms. We also know that patients who have high prolactin, this can increase psychosis vulnerability, especially in women, because it decreases estrogen, and estrogen is thought to be protective against developing psychotic symptoms. So hormones are very important. Just a couple more thoughts on some endocrine causes of secondary psychosis. For the thyroid, we obviously, when someone, we'll talk a little bit more about medical workup later, but we want to check their thyroid levels, their thyroid stimulating hormone levels. Your thyroid hormone, as I said, really controls a lot of things in the body, heart rate, energy, temperature, etc. And rapid correction of thyroid levels can definitely exacerbate psychosis. Here's some of the physical changes you would see in someone with hyperthyroid. This is called exophthalmos, where their eyes are popping out more because of their thyroid hormone being high. These are your adrenal glands that produce cortisol. Again, cortisol, the stress hormone, really, really important for regulating metabolism, blood sugar, blood pressure. Also, other hormones from the adrenal glands that regulate your electrolytes in your body. If your electrolytes are off, then that can cause some neurological symptoms as well. And then lastly, parathyroid hormone regulates calcium. Calcium is very involved in how neurons are firing. If neurons are firing strangely, then we can have some psychiatric symptoms, including psychosis. All right, moving on to nutritional causes of secondary psychosis. This is it's very vital to check if you're having a patient with the first episode of psychosis and you're trying to rule out any non-psychiatric causes. Vitamin B12 is deficiency nearly has double the risk for psychosis. So that's a very, very important thing to check. We also monitor for deficiencies in other vitamins like folate, niacin, and thiamine. A bit more about vitamin deficiencies as well as toxins. Vitamin B12 is by far the nutritional deficiency that's most associated with secondary psychosis. Patients can have auditory visual hallucinations. They also develop what's called macrocytic anemia. So we would see that again on labs as well as the low vitamin B12. Um, we also see niacin and folate deficiencies causing psychiatric symptoms, again, including psychosis. Here's a rash that you can get from a niacin deficiency. Again, we're seeing these clusters of symptoms where psychosis is just part of that cluster of symptoms that would indicate a cause of secondary psychosis. It wouldn't occur alone in niacin deficiency. And lastly, talking about heavy metals. This is something, not these heavy metals, these heavy metals, the like lead, mercury, arsenic. Sometimes it's low yield, but some people do perform a heavy metal screen when patients come into the ED or they're having their first episode of psychosis. But it may be worth it.
One related question. So is it worth getting a B12, niacin, folate, and thiamine levels even if there's no anemia or anemia? Sorry.
We always, it depends on who you check, who you ask. This is something that I think is very exciting. There's a lot of very dedicated people in this field right now who are working on trying to understand what would be a standardized, evidence-based psychosis, first episode psychosis workup. What would that mean? Because we have to balance like quite a few things when we're ordering tests, like how likely is it to return something that's actually clinically useful? How likely is it to return something that's treatable? Is this a good use of healthcare resources? It really depends on from person to person. I would run vitamin tests for all three of those, but I'll talk a little bit more about it's a little bit more complicated than that. I talk about medical workup later in the presentation, and we can get to that a bit more. Excellent. All right. This and next we'll talk about infectious causes, which honestly is the most fascinating cause of secondary psychosis to me. First, we'll talk about bacterial causes. Neurosyphilis is fascinating. In medicine, we call syphilis the great imitator because the infection can hide for years. It can present in so many different ways. And one of the ways that syphilis can present, sometimes decades after, sometimes weeks to months, but sometimes decades after the person is infected, is neurosyphilis, which is when the syphilis infection is in the brain. Oftentimes, this presents with personality changes and memory loss 15 to 25 years after the initial infection. So crazy. And this also happens more often in patients with HIV. HIV, of course, your immune system is weaker, so your resistance to developing a serious brain infection like neurosyphilis is elevated, which makes sense. We can also see bacterial causes of secondary psychosis from tuberculosis, from bacterial and other types of bacterial meningitis as well. I forget the exact statistic, but there was a time before penicillin was discovered, and penicillin, by the way, is the cure for syphilis. Before penicillin was discovered, patients who were hospitalized in mental asylums, like a very large percent of them, were had neurosyphilis, and that was the primary cause of symptoms, and that wasn't known at the time. They just thought that they were, had a psychiatric condition. So it's quite fascinating just how psychiatric in nature neurosyphilis can present. Other viral causes of secondary psychosis include herpes simplex virus, especially the HSV-1, which is the virus that gives cold sores. Sometimes the herpes virus, for whatever reason, really likes the temporal lobes. So for that reason, patients can have olfactory hallucinations, feelings of deja vu, and other psychiatric symptoms like psychosis. HIV can also directly go to the brain, especially in patients who are pretty progressed in their illness and cause cognitive impairment, psychiatric symptoms. And then there's other viruses like cytomegalovirus, varicella zoster, and Epstein-Barr virus that can cause brain infections with psychiatric sequela as well. To talk a bit more about these, encephalitis, such as that's caused by an infectious, not autoimmune encephalitis, just encephalitis from an infectious cause, can be caused by herpes, enterovirus, West Nile. This often presents as fever, seizures, hallucinations, confusion, muscle weakness, and partial paralysis. Lyme disease can also sometimes cause psychotic symptoms. If you go in the woods in the Northeast, definitely wear your bug spray. Cause it. This is the Ixodes tick. It's the carrier of Lyme disease. Oftentimes people get these bullseye rashes on
It's
their.
Ruth. Hi. Give them a
Hello? Okay, we're gonna keep going. Oftentimes with Lyme disease, we see fever, headache, joint pain, and then abnormal movements, and then we see psychosis in that as well. We talked about HIV/AIDS as a cause of primary or secondary psychosis. And then we talked about syphilis as well. Syphilis can go anywhere and everywhere in your body. It's quite interesting. Here's the palms and soles rash that we associate with secondary syphilis. So this isn't the primary initial infection. This would be later that someone develops this. But syphilis can go anywhere. Again, the great pretender. It can even go to your brain. And that's it going everywhere. All right. And then this is very important to note because this is why vaccines are important. Childhood CNS infections can increase the risk down the line of patients developing psychotic symptoms. Those are just some of those infectious agents that can contribute to that. And interestingly enough, in the literature, we see a lot of cases of COVID-19 acute infection associated psychotic symptoms. However, before we talk about this, it's very important to note that current evidence does not support a causal relationship between COVID and psychotic symptoms, but does support some sort of association. Most presentations may be coincidental, maybe multifactorial. Another potential confounding source is that patients are sometimes on corticosteroid treatment. Corticosteroids are notorious for causing psychotic symptoms in patients who are taking them. And there also could be some sort of either autoimmune, inflammatory, or other hyperactive immune system response to the patient having COVID that would result in psychotic symptoms. However, I still wanted to note it because this is something newer. I guess we're now 6 years out from COVID, or the peak of COVID, but still worth talking about and at least mentioning. We want to talk about, we treat younger populations. So we, of course, want to talk about genetic causes of secondary psychosis. About 2.4% of patients with schizophrenia involve rare high-risk genetic mutations or copy number variants. We now weigh these two hypotheses of the common disease, common allele. So is this a common disease with an allele or like a part of your DNA that just occurs a lot in a person's DNA, and that's the reason they have a predisposition to psychosis? Or is this a rare allele that just occurs in some people and puts the person more at risk of developing psychotic symptoms? Here's a list of some of those gene loci that are associated with increased psychotic risk and also risk of developing other specific genetic disorders. We're going to talk quite a bit about the first one, which is 22q11.2. And it's a deletion. We'll talk about that on the next slide. This has always fascinated me, and I think a lot of people in the psychosis world are really fascinated by 22q11.2 deletion syndrome, aka velocardiofacial syndrome, aka DeGeorge syndrome. It has three names. Um, and this is the most common genetic abnormality we see in this field, meaning with working with patients who have schizophrenia. It's a very rare disease, but these patients have a very high risk of developing psychosis, a psychotic illness, a psychotic disorder. And it looks like standard schizophrenia. So it's really fascinating. And including that major distinguishing factor, like a decline in cognitive functioning. So it's not like they're just having psychotic symptoms, they're having psychotic symptoms with a decline in cognitive functioning, like we see in our patients with schizophrenias, and also decline in verbal IQ. And these psychotic symptoms typically start around age 11. I want to point out that the psychosis risk down here in the left corner, 25 to 30% of patients with DeGeorge syndrome develop schizophrenia or schizophrenia-like psychosis by adulthood, and 41% of adults over age 25 have psychotic disorders. So really, really fascinating. And again, the symptoms are very closely mimic idiopathic schizophrenia or like primary schizophrenia that we see and treat every day. So very, very fascinating. A lot of different genetic conditions have associations with psychotic symptoms, some more, some less. I just wanted to point out a few. Klinefelter syndrome are patients who have two X chromosomes and one Y chromosome. They have about 4 to 10% times risk of developing psychosis. Turner syndrome are patients who have one X chromosome and no second chromosome, so just one X. These are patients, they have short stature, they have scoliosis, they have heart defects, kidney defects, and they're actually 3 times more likely than the general population to develop psychotic symptoms. We spoke about DeGeorge or 22q11.2 deletion syndrome. And this syndrome has associated heart defects, thymus. They're born typically without a thymus. They have cleft palate. They have low calcium, and they also have abnormal facies. And then lastly is Huntington's disease, which 5 to 16% of these patients have psychotic symptoms. Huntington's is just, oh my gosh, it's just such a difficult disease. It's autosomal dominant and it doesn't present until adulthood. So oftentimes when people are displaying symptoms, they've already had children. They develop writhing movements. They develop a lot of psychiatric symptoms like aggression, depression, and also psychosis. I've taken care of patients who have psychosis secondary to their Huntington's disease who are younger, like more like first episode sort of age. Of course, their symptoms are secondary to their medical condition, but it's quite a difficult disease for families and patients to deal with. All right. And the last genetic conditions I want to talk about are inborn errors of metabolism. These are like Wilson's disease, which is your body can't transport copper. Your body actually needs a decent amount of copper, but you have to be able to take it in from your gut and also excrete it back into your gut to get rid of it. And these patients cannot do that. There's other rare inborn errors of metabolism like porphyria, which can disrupt neurotransmitter systems and result in psychosis. We'll talk about those a bit on the next slide as well. People always talk about Henry VIII having acute intermittent porphyria because of his temper and because there are some genetic ties to the royal family. I don't know how much that's like borne out, but if that's always helped me remember it. But again, these are patients who have trouble with synthesizing parts of their blood. And so they have this like toxic buildup of these incomplete parts of their blood, and they get attacked. They get horrible abdominal pain, and they can have depression, mood swings, etc. And we talked about Wilson's disease and your body's inability to secrete copper. You can have psychiatric symptoms manifesting from this. Patients have movement difficulties. They also have something in their eyes called a Kaiser-Fleischer ring, where the copper builds up around your iris. And then again, there's a lot of other inborn errors of metabolism that have associated psychotic features. But to zoom out, what I really want you to see is that there's a lot of psychosis is a symptom and it's involved in a lot of different things. So you should always be looking out for these secondary symptoms, and not just like psychosis as kind of this like single heralding factor of a secondary cause of psychosis. All right. Next, we'll talk about autoimmune causes. First, we'll talk about neurologic autoimmune causes of psychosis. This is so fascinating. Autoimmune encephalitis is critical to always have in your differential with any first episode psychosis. And anti-NMDA receptor encephalitis, the immune system attacks the glutamate receptors in this central nervous system, and about 34% of these patients present with schizophreniform symptoms. And well, we're not going to talk about lupus right now, are we? No. But very fascinating. And an anti-NMDA receptor encephalitis is the most common that we know of, at least, and also the one that we see present with psychotic symptoms. We'll come back to that in a second. We also have systemic autoimmune illnesses that can cause psychotic symptoms like lupus. Up to 80% of patients with lupus develop neuropsychiatric symptoms, which is fascinating. And we already discussed multiple sclerosis. What I found really interesting is that most systemic autoimmune illnesses do have an association, at least to some extent, with psychosis, but there's two that have a negative association, meaning that they're less likely, at least in this meta-analysis I looked at, to develop the psychotic symptoms. I found that very interesting. All right, to talk a bit more about a selected few autoimmune causes of secondary psychosis, we'll talk about lupus. Lupus patients usually have psychiatric symptoms within 1 year of developing the illness. They have this rash across their face that's called a malar rash or a butterfly rash. House MD, the joke on House is that they always, if you watch this TV show, is that they always think it's lupus, but it's never lupus. This is because lupus affects almost every organ system and presents so differently. And one of those organ systems it affects is psychiatric symptoms or the brain. Our friend Selena Gomez has lupus. She's had severe kidney disease from lupus and has had to have a transplant. You can also have rashes from lupus that look like this. let's talk about autoimmune encephalitis. So, Brain on Fire by Susanna Callahan is a book that really popularized autoimmune encephalitis. She is a patient who had this illness, and I believe he's a neurologist, came across her in the hospital and kind of recognized what was going on, and really brought her back to her baseline. And it really is fascinating when you treat this, when you come across it. Patients do, you put them on the medication for it, and they do return to their baseline, at least in my experience, the cases I've treated, very quickly. So very, very fascinating. This would be, of course, a more intense workup. This would be someone who's probably admitted to the hospital. They'd probably have a lumbar puncture to look for the antibodies that are affecting the brain. And then you would treat them with different immune drugs to calm down that autoimmune reaction where the body is attacking itself. That's the Brain on Fire movie. All right. And then I wanted to mention quickly substance-induced causes of psychosis. Of course, substance intoxication isn't a medical condition. It's a state of intoxication. But since we are talking about secondary psychosis specifically, meaning non-psychiatric causes, I think it is worth talking about stimulant intoxication. Cocaine and amphetamines, definitely a high driver of psychosis. Patients also typically develop persecutory delusions as well as formication. Formication is that feeling of bugs crawling on your skin. And Adderall abuse can also look like this as well. It looks very similar to amphetamine abuse. Cannabis, as we all know, I'm not going to go into this too much. As we all know, cannabis-induced psychotic disorder is so common in our patients. 44% of cannabis-induced psychosis patients are later diagnosed with schizophrenia spectrum disorder. So there's like this direct link there. And then alcohol, hallucinogens, and sedatives can also cause psychotic symptoms. I'm going to skip this. All right. And then the last secondary cause of psychotic symptoms are medication induced or iatrogenic, meaning that this is coming from the medical system. We have many different medications that we know can cause psychotic symptoms, particularly in the elderly. Especially medications with anticholinergic agents like Benadryl or antihistamines. I mentioned steroids earlier. Steroids are pretty infamous for causing mania and psychosis in patients who are typically those who are more predisposed to it. They have like an underlying psychiatric condition like schizoaffective disorder or bipolar disorder. And then other medications like anti-Parkinsonian medicines, like dopamine agonist. If you think about someone with Parkinson's, they have low dopamine. That's one of the causes of the illness. You give them a dopamine agonist, and if you give them too much, then they can present as a bit manic, sometimes a bit psychotic as well. All right, notice the cats as we continue on. They're getting a little bit more unhinged. So how do we diagnose secondary psychosis? So our diagnostic framework is guided by three pillars. One, biological plausibility, where we're asking ourselves, is there a physiological mechanism? Temporality, which did the medical condition precede the psychosis? And three, typicality. Is the presentation atypical for a primary disorder? In any patient over the age of 40, primary psychosis must be considered a diagnosis of exclusion until a secondary medical cause is ruled out. Again, it's much more common in patients who are outside of that age range, where we do see the first episode of psychosis, like young adults, late teens, 20s, maybe even 30s, where we do see that, yes, this is the typical presentation of a primary psychiatric disorder, but anyone older or anyone really young, you want to take a close look. Other special populations to mention, one other one is delirium. So sometimes when older people are in the hospital, their brains aren't doing, it's usually older people, it doesn't have to be. Sometimes when people are in the hospital, their brains are not functioning well, typically at baseline, and then being in the hospital is confusing for their brain. And they do have episodes of psychosis where they're confused, they have altered mental status, they'll have visual hallucinations, and that's oftentimes something we have to address. I'm going to take a sip of my coffee. So, how do we work up these patients medically? Again, remember, psychosis is a symptom. We're trying to find the cause, medical or psychiatric or non-psychiatric. And with every presenting symptom as a doctor, I'm just trying to understand why this symptom is happening. So, what am I doing to find that out? First, I want to take a really good history. This may involve me talking to collateral or family members, but I want to know the onset of the symptoms, the duration, the character. Are they waxing and waning? Meaning, are they coming and going? Have they increased over time? How severe are they? How much is this affecting their lives? Are they having any physical symptoms? Do they have any genetic issues? Is there a family history of psychotic symptoms? And not even just psychotic symptoms, family history of substance use disorder, family history of mood disorder, family history of anything psychiatric, but definitely especially psychotic symptoms. And again, are there concurrent symptoms going on? Next, I'm going to do a pretty intensive physical exam and cognitive exam as well. I want to do a mini mental status exam or a MOCA, which are both short ways of testing a broad spectrum of the person's cognitive capacity that you could do in an inpatient unit or you could do in the emergency room. That's going to let you know, is this person cognitively impaired by current symptoms? If someone's cognitively impaired by current symptoms, that points you more in the medical direction typically. Dementia aside, we're not talking about older people right now. We're talking about our people. So if someone is more cognitively impaired, that's going to be, and by that I mean they can't tell you where they are. They can't perform basic functions for themselves anymore. That's going to be something that's a little suspicious. Whereas someone who maybe was a first episode, they may be floridly psychotic, but they can tell you that they're at the hospital. They can tell you their name. They can tell you what time it is or what they did yesterday. A physical and neurological exam is going to be really important. We'll talk about some of the neurological examination findings on the next slide. And then next, we're going to run some laboratory tests, which we'll go into more details in a bit. We'll do a basic health screen. I want to know how their kidneys are working. I want to know how their liver's working. I want to know their electrolytes in their blood. I want to know their blood counts. Do they have a white count, which could indicate infection? I want to know a lot of these things. And again, we'll talk about the rationale behind that in the next slide. And then lastly, you have to decide if you want to obtain imaging or other diagnostic modalities like an MRI, which is a type of head imaging, or an EEG, which again is looking at someone's brain waves. So let's talk about those in more detail. For a neurological exam, I want to see their reflexes. I want to see if they're having any issues with their pupils, which could indicate multiple neurologic causes. I want to see if they have a copper ring around their eye. Again, very rare to have Wilson's disease, but could you? Absolutely. I want to know if they have diminished vibration sense, which would indicate vitamin B12 deficiency. Nystagmus, which is abnormal eye movements due to defects in your brain, in coordination. These are all things I'm going to look for on my physical exam. Those are more for neurologic findings. We also have other different types of findings that we can find. Oh, these are the answers for the ones on the left. But anyway, we're going to move on. All right. So the way this isn't just in psychiatry, this is kind of medicine in general when doctors are picking what tests to run and what to do next and what's our diagnostic way that we're going to think about the current issue. This is one way to go about it. So initially we might get a complete blood count. Again, I want to see their hemoglobin. I want to see their white count. I want to see their platelets. I want to look at comprehensive metabolic profile, would tell you their liver and kidney function, their electrolytes, a couple other things. I want to see their thyroid. I want to do a UTOX because I want to know, do they have any substance in their system that could be altering their mind and bringing on these psychotic symptoms? Parathyroid hormone and calcium, very important. And then talking about vitamin B12, folate, and niacin levels. Additional tests to consider, or maybe you would get these at baseline anyway. It just really depends on the person, would be HIV and syphilis. Again, probably the two most common infectious causes that we can easily test for of psychotic symptoms. And do we want to get neuroimaging? I think there's kind of a lot of back and forth on that. I personally try to get at least a brain MRI on every patient I see in Aspire, just because I think there's a utility in doing so. And if you suspect a seizure disorder, you may want to get an EEG. And if you're really suspecting something like a CNS infection or autoimmune encephalitis, like something like pretty big and scary, then you would definitely want to get a lumbar puncture. And at that point, if someone is presenting with pretty severe symptoms, it may not be us in psychiatry doing the workup anymore. It might be neurology or internal medicine, and we're just on board consulting. This is one of the recommended medical workups, but by no means exclusionary. And then lastly, we're going to talk about some treatment principles. Again, we want to, the core rule is we address the underlying medical condition. We treat the fever, we treat the infection, we treat the electrolyte imbalance before reaching for antipsychotics. And it's really important to remember that in cases like autoimmune encephalitis, immunomodulatory treatment has a 94% response rate. So we want to uncover these secondary causes of psychosis, so we can return patients to their baseline. And then last section, challenges of diagnosing secondary psychosis. We're going to talk a bit more about the Bradford Hill criteria for causation as a way to sort of say why this aspect of the field is so difficult. I'll get into it in a second. To help us navigate the challenges of causation, we use the Bradford Hill criteria. And this framework asked, is there a dose effect? Is the association strong and consistent? Does the effect always follow the cause? And by applying these criteria, we move from observing a correlation to identifying a true causal link between a medical insult and a psychotic symptom. So it's really difficult about secondary psychosis is that many patients have underlying medical conditions already. We know that patients with idiopathic psychotic illnesses have have comorbid medical conditions in general, right? So it's difficult because how do you draw a causal link from one to the next? Well, this is where we can look at the Bradford Hill criteria. So we always want to say, is this the cause of the psychosis or is it just a coincidence? So we look at temporality first. Did the medical symptom or substance use precede the psychiatric break? Then we look at the strength of the association. So for example, we know that a 22q11.2 deletion increases psychosis risk 60-fold, which is a massive red flag. And then lastly, we also consider biological plausibility. So does it make sense that a thyroid storm or a hit to the temporal lobe would scramble dopamine signaling? And by running our thoughts through these filters, again, strength, consistency, temporality, we move away from guessing and towards a precise evidence-based diagnosis of secondary psychosis. So here's how we want to think about different differential diagnoses on our list for a patient who's presenting with what may be secondary psychosis. So we want to put some potential diagnoses in this box, illnesses that are common and typical. So common and typical would be someone who has a common presentation of psychosis. It would also be drug-induced psychosis. We see this a lot. We know what it looks like. We know how it presents. Next are illnesses that are common and atypical. So is someone have a question? Okay. So a common illness like epilepsy an atypical presentation of epilepsy would be someone who has ictal psychosis or post-ictal psychosis. But we know it exists. Uncommon diseases with typical presentations would be something like 22q11.2 deletion syndrome and some uncommon disease, but a typical presentation of that would be someone who has psychotic symptoms. And then lastly, is an atypical illness or uncommon illness with an atypical presentation, which would be like it would be rare for pheochromocytoma, which is a type of kidney tumor, to have associated psychotic symptoms, but not unheard of. So we're trying to say, again, is the disease common and is the symptom common? And how likely is it that there's a causal line here? All right, and to conclude, a secondary psychosis represents a significant minority of cases that are often reversible. A comprehensive assessment of red flag symptoms and a systematic diagnostic workup are essential. By detecting these causes early and tailoring treatment to the specific etiology, we can significantly improve and hopefully sometimes completely restore the lives of our patient. All right, pay attention to Lewis Wayne's last cat. It's just gone off the rails. So thank you everyone so much for your time. I'd really like to acknowledge my mentor, Dr. Maturi Keshavan and Lauren Good for their contributions to this work. At this time, I'm happy to take any questions or comments you may have.
Yeah, thank you so much, Megan. We've gotten a couple
Yeah, I
coming through in
see.
the chat, but please, yeah, keep them coming. Yeah,
Geez.
first one, yeah, great question. To what degree are ED doctors trained to think through these possibilities and run the kinds of tests that you're talking about? And what is kind of the experience of somebody who would be presenting at an ED with what looks like a psychotic break, but it's kind of unclear?
That's a great question. And I think it really varies. As you can see, patients who have these very obvious medical symptoms as part of and psychotic illness is kind of like part of that. That may be someone who immediately is getting a pretty hefty medical workup versus someone who's maybe their psychosis is maybe the most marked symptom that they're having right off the bat. That's someone who may come to psychiatry first. The way the ED works is they're screened by the ED docs in general, and then they bring psych in. And typically, anyone with a psychosis sequela psych is going to be on board in some capacity. It's just a matter of what they decide is like the best next step. Does the person get admitted to medical? Do they get admitted to psychiatry, etc.? I think when patients are I'm thinking about where I trained. I don't have a lot of experience where I currently am because I'm not an inpatient doctor. But where I trained, we would advise on the first episode workup in the ED. And if there were any acute concerns for something non-psychiatric being the primary cause, we would typically defer to the ED medicine doctor. So they are trained to look for these things, but I would say psychiatrist above and beyond would be brought in no matter what to probably advise on this workup. That's been my experience. Great question.
And yeah, following that one, can you talk about the CT versus MRI for first episode cases where head imaging is warranted, with the note, particularly when insurance is pesky?
Oh Lord, I know, right? Oh my gosh, I know that's like the bane of my existence. So CT is a type of head imaging, just so everyone knows, it's like an X-ray of your head, but it's like multiple slices of it. It's very quick. the biggest utility of CT is if someone, it's essentially shows you basic structures and it shows you blood or no blood. So someone who's like had a stroke would get a stat CT because you'd want to see blood or no blood. Are they having a type of stroke that bleeds? MRI, you're going to see a lot more detail, and specifically if you use something called contrast, which is like it's like they inject it in you and it goes everywhere in your body. But if you're doing imaging, it goes to your brain. It kind of like lights up different structures. That would be the preferred modality because that would probably show you more of what you're looking for, which would be things like tumors and things like structural abnormalities and depth. And typically someone who I don't know, insurance typically wants people to get a CT head before they'll cover an MRI. Sometimes you just have to, comply with that, unfortunately. But I think it's always, it's definitely always worth it to get an MRI if you can. But, I would say I'd rather have a CT than nothing.
And I
Great
mean,
question.
you talked about this a little bit before too, and very much related to that, the kind of balance of, in an ideal world, you could get all of this information and have everything for a person to really be able to make that. But then, yeah, what's the kind of balance that you strike
Great
between when
question.
it's indicated, yeah, et cetera?
Yeah, I'm working on a project right now where we're looking at trying to format some sort of like evidence-based medical workup, but part of the project is looking at how do we be good medical stewards of the resources that we have. Because you have to realize like these are really intensive time and cost intensive things, and we do have to be good stewards with resources, and that makes sense as well. There's also a harm, and sometimes, and I'm not saying with this specific topic, but just like in general with medical testing, there's a lot that goes into thinking about like what is a positive result and what's not, like where do you draw the line? And if you keep testing for things, you probably will find something, but it doesn't mean it's relevant to what specifically you're looking for and what you're studying. And that could lead to further workup for the patient that's unnecessary. Here, let me stop sharing so we can have a face-to-face conversation. We have to be good, big picture, we have to be good stewards of our medical resources, even though it would be lovely if everyone could have, every test.
Is it okay to unmute and talk? I didn't see any other questions in the chat. Kelsey, did you have other ones you wanted to read out next?
No, go ahead.
Cool. Cool. Hi, I'm Krissa. And I was just typing, you just spoke, Dr. Good, to what I was typing in the chat, which is just
Hello.
as a psychosocial provider in a first episode clinic, when families and clients are hyper focused or just focused on a medical cause for psychosis, though as a physician, you do not actively suspect one, but we don't want to rule it out completely ever. Do you have good common language that you use? And you just spoke to it just a bit there about being a
Yeah.
good steward and not wanting to, order so many tests that we're going to find something that's going to kind of lead them to have a stronger belief that it's a medical cause.
Yeah, I love that. To me, psychiatry is medical. So that's what I don't like saying. That's what I hate saying, like psychiatric. That's why I say psychiatric and non-psychiatric or medical. I don't like saying like medical and non-medical because this is medical. Like these are
Thank you.
idi yeah, idiopathic psychotic disorders. People have studied them for hundreds of years. There are things in our field that we do need to define more strongly and more concisely, but at the end of the day, we know that this is a brain illness, and it's helpful to phrase it that way to families. At the same time, I do think we do owe patients some sort of medical workup, and some sort of way to say, especially if they're really young or they're outside of that normal range. We do want to think, hey, what is the etiology of these symptoms? It's really important for us to give patients answers that are correct and based in reality. Dr. Keshvan, do you have a thought?
If you're muted.
You mean it?
Yeah, I have a number of thoughts, and I want to be brief. This is a topic that has been of great interest to me. First of all, thank you, Megan, for a wonderful presentation. The field has been confused for 100 years as to
Yeah.
how to um, name or define people who have psychosis that could be directly related to one or other kind of medical cause. As I was, growing up as a medical student and then as a resident, the common way we would distinguish different kinds of psychosis into the so-called functional psychosis and organic psychosis, as if there were no organic lesions that were demonstrated, they all had something, nothing to do with the brain, or psychogenic. Those were the terms that used to be used. And then the field moved a little bit forward, and we began to distinguish between what we call primary psychosis and secondary psychosis. What you were presenting today mostly is referred to as secondary psychosis and so on. But that brings up the question, the primary secondary distinction. This is something that you and I have written about, Megan. Um, so the terminology problem. The primary versus secondary, as well as the term that gets bandied around called idiopathic psychosis, is a reflection of our ignorance. Psychosis that were thought to be functional, like in 1920s, 30% of mental hospitals had those psychoses, ended up being called neurosyphilis after the treponema germ was discovered under the microscope. And many people that I used to see in the 1980s in my residency days, that we had no idea what they had, but they had a funny looking face and they had a cleft palate. They ended up looking like they ended up being diagnosed with velocardiofacial syndrome or 22q deletion syndrome that you now describe. And I used to see patients who were so severely ill and catatonic would never get better with anything over the months of treatment. Nowadays, many of those cases in retrospect would be considered as an MDA encephalitis. So I think the whole term of primary or idiopathic psychosis is a shrinking field. It'll disappear as we know more about underlying causes. So that's why I don't use the word functional psychosis or organic psychosis or secondary psychosis in my terminology with patients. So what do I say to patients? I say that you have symptoms that we believe come under a broad category of what we call psychosis, which is characterized by distortions of distinguishing between reality and unreality sometimes, and perceptual alterations and so forth. We believe that there are brain-related alterations here, but we believe, that our field is not advanced enough to prove that to you. But sometimes we have an idea even without brain scans showing that. And I explained to them how a patient with hallucinations, might understand it as an informational processing system that has gone wrong. For example, a recent patient I had, a biomedical engineer, I gave her the explanation that her brain might have a signal noise problem. The confused thinking is related to low signal in her brain, and the chatter inside her head, the hallucinations might be related to the noise because of a low signal to noise ratio. And she understood, and she was willing to agree to go on Abilify. Then I explained to her that dopamine fine tunes this information processing system so that the signal is increased and the noise is decreased. So I think many patients that we see might benefit from an explanation, a mechanistic explanation of what they might be having, which may be a brain-related explanation that we can come up with in most cases. Someone who has negative symptoms, we could say, your brain juice is kind of running low or something like that. Or someone who has high sense of paranoia, your other warning systems in your brain might be hyper alert or something like that. So I think we need to use neuroscience language even for the so-called primary psychosis. That's my point one. Point two is thinking that way. All psychoses are secondary to something or the other. So instead of thinking of secondary psychosis as that rare thing, we should think of everybody potentially having something that we can understand better. So therefore, everybody should get a good medical workup. So this is where I stop.
Dr. Ketchman, it's wonderful to hear you say brain juice. That's just really endearing.
Thank you. That's what it is. It's easy to normalize it. Even I run out of my brain juice sometimes in the morning and I haven't slept well. So,
Or
it is
I
easy to,
sometimes I call it diluted brain juice. Like your brain
yeah,
just got diluted a bit. So I like because
yeah,
it's a visual, you can picture what diluted juice tastes like, right? So
exactly.
it's just
Right.
so such a great.
Well, and I'd say you both have somewhat addressed the question that we've got in the chat, but I want to call out. So, asking, would it be safe to say that part of all first episode programs should have a medical workup? And it sounds like this is approaching the diagnosis of psychosis from more of a functional medical perspective. So, can you speak to any differences between, your practice and that perspective? And how those providers can help to assist first episode programs in improving those outcomes.
Yeah, I would agree that patients at some point should have a first episode psychosis workup. Ideally, that's when a patient, I know we get most of our referrals from inpatient hospitals. Ideally, the patient's in the ED and someone's doing this and is mindful too. I know here at BI we do have a protocol for it that the residents know. Or they're at the inpatient hospital and someone's been thoughtful enough to do this for the patient. But yeah, psychosis is a symptom. You have to, for like any, if it was a fever, you wouldn't just automatically treat it like it was an infection. You would want to work up and say with confidence, like this is what I think is going on, so I can offer you the best treatment and therefore restore you to functionality and your get back to your life, because that's why we're doing this, right? Like we're trying to help our patients live the lives they want to live. So yeah, absolutely.
Thank you. Fantastic questions so far, everyone. I really love the comment. I'll just call out that it's important to be humble that there might be other underlying non-psychiatric or medical causes of psychotic disorders that we can't detect yet. And yeah, there are many ways that people with schizophrenia spectrum disorders have dysfunctions in other organ systems. So yeah.
Absolutely. Yeah, no, I mean there definitely are. There's definitely ways to test for the idiopathic schizophrenia that we know and we treat every day. There's going to be a way to understand that at a level that's more accurate than what we understand now. And that will likely involve some sort of medical testing to give us a clear idea of what's going on. Um, there's so many things we don't know. And it's so important to approach every patient with the curiosity of trying to figure out what's going on and giving them kind of like the reality of, what's going on with their body and their mind.
So, there is one other thing that I would like to add, which is um, medical workup in patients with psychotic disorders doesn't have to be a full workup at the beginning and leave it alone. It has to be an ongoing process throughout the course of the individual's tenure with us. And the reason I say that is because medical conditions could be the cause or the consequence or even coincidental. There are people, of course, as Megan pointed out, that have a psychosis that can be directly traced to a medical condition causally. That's important. The second is there are people who I've seen, after years of treating them, incidentally, I come up with something and I get a test, and here you go, and they have a problem that had never been detected, like a severe diabetes. or another autoimmune condition, and so forth. So they are not immune to medical conditions. They are manifold more likely to develop medical conditions in their course of illness. So one should keep that, being vigilant on that all through. And they could be coincidental. They could have a medical illness and a psychiatric illness both at the same time. So one should never give up the idea of a medical workup in these patients.
Thank you so much for this conversation, Dr. Good, and thanks for being here, Dr. Kashanat. It's just such a timely conversation that we should always be having, and it really helps, I think, as a psychosocial provider, clinician in an FEC. I have conversations all the time. In fact, just yesterday, the very unfortunate conversation of a client saying, if schizophrenia is my diagnosis, I don't think I can live. Like, I can't live with the shame of that. Literally, someone said that to me yesterday. And if we aren't educated enough to have these conversations, we are going to really allow our clients to walk away in a hopeless situation. So just learning all we can and being able to use the language that you're using here is so important for all clinicians, especially in the early psychosis and CHR world. Thank you.
Yeah, thanks for that point. You bring up the issue of how much people with this illness and their families, dislike the term schizophrenia. And we did a study a few years ago, led by Raquel Michelon Gately, which showed that out of 1,100 people that we surveyed, many of them people with the illness, 74% preferred to change the name schizophrenia. So, we gotta do better than that.
And we have to be honest with our clients as well. It
Yeah.
doesn't do them any good to pretend that they're just
Yeah, but
have to be honest and authentic.
we should think about a better name for sure.
Yeah,
And
sure.
that requires understanding the causes so that we rename the illness based on its cause and what happens in the brain, as opposed to an adjective, which is what it currently has become.
Yeah, well, thank you both so much, and yeah, everyone for joining us today during your lunch hour. I know for some of you, I did post the post-event feedback form in the chat. Please fill it out. It is very helpful for us. But aside from that, I saw also Megan posted her email, so happy to follow up with anyone who's interested. But yeah, thank you all for coming today, and
Yeah,
we'll
we'll also
post the
follow up with
recording
a
and sound
survey to
soon.
everybody as well about
Yeah,
these presentations. Yeah, thanks.
thank you.